When managing tibia fractures, say BOST and BEPRAS guidelines. British Association of Plastic and Reconstructive Surgery and Aesthetic Surgeons, BEPRAS and BOST. BOST, British Association of uh, Standards of Trauma and Orthopaedics. BOST guidelines for tibia fractures. Serial neurovascular and compartmental syndrome observation. IV antibiotics 1.2 gram within 3 hours of injury. Clindamycin if the patient is allergic. Cross-contamination are agriculture, sewage, and vascular impairment. Prompt surgery within 6 hours. Number 4, compartment pressure by 2 incision technique or on lower leg for compartment syndrome. Number 5, orthoplastic approach. Number 6, gross contamination remove all to allow photography. Saline so gauze impermeable dressing and splintage. Number 7, antibiotic cover for 72 hours. Number 8, vac dressings if definite coverage is delayed, ideally for 3 to 7 days. Number 8, pediatric treatment wounds would be treated in a similar way, but not necessarily similar to the fracture. Stable fracture. 5 degrees of varus of valgus, 10 degree of procurvatum, 1 centimeter of shortening, 50% of cortical apposition. Place in above knee plaster, functional brace at 4 weeks. Wedging technique. Mark area of the fracture on the cast, cut open more than 90 degree of circumference, intact portion at the apex of the deformity, lamina spreader used, put a cork wedges, if displaced, perform close reduction under GA. Wolf trial. Wolf trial has shown that negative pressure wound therapy compared with standard therapy did not improve self-rated disability index in 12 months. This does not support negative pressure wound therapy for severe open fractures. Tibia nail, protect is the expert nail which is antibiotic loaded, and incision can be suprapatellar, transpatellar, medial patellar or lateral patellar. Remember, suprapatellar nail needs a special inventory. In AP, the entry point is in line with the axis of intermedullary canal. This is medial aspect of lateral tibial spine. In lateral view, the entry point is just below the anterior articular margin of the tibial plateau. Blocking screw, if there is it should be always placed in concavity. So if there is a valgus deformity, it should be lateral. If there is a procarvatum apex anterior deformity, placed posteriorly. Can use wires, can use unicortical plates. Twisting movement to advance the nail. Monitor nail passage across the fracture. Control in 2 planes to avoid malalignment. Lock distal first and then backstroke technique to prevent fracture gap. Other technique is push pass technique. Consider 3 interlocking screws in short segment of the distal and proximal fracture. Superpellar nailing is easier, reduce the incidence of knee pain, reduce the incidence of procarvatum. Bandari et al. 2000, unreamed nail reduced the incidence of reoperation, infection and malunion compared with external fixators. Decrease time to union and weight bearing compared to the non-operative treatment. So Bandari et al. Unreamed nail is better and reduce operation instead of external fixators. Regarding the X-fix, higher rate of malalignment compared to the IM nail.